Great. All right. Well, thank you for the introduction. Great to be here and doing this talk. Obviously, clinical informatics is near and dear to my heart. As the let's see, let's move through that. Jump to my next slide there. So as mentioned, I'm currently the Associate Chief Medical Information Officer here at Carillion, but also moving into continuing to look at well-being. And so I consider myself an epic well-being champion, and that will play into some of our discussions today. So the obligatory disclosure slide, and so with this presentation, I have no financial disclosures, but do want to take a moment and talk about some personal disclosures. In the title, we are going to be talking about equity, and I am not an expert on equity. I'm not an expert on diversity and inclusion, but I'm getting better every day. But as fate would have it, I am talking about equity, and there is a good probability that I may say something that someone finds offensive. And so as we start off, that is not my intent. And I kind of compare myself to Sheldon from The Big Bang Theory. And just like Sheldon, sometimes I say things and I don't realize that I've offended that person or group. And so just to put it out there in the beginning, if I do say something that that you find offensive, please reach out to me and let me know, and I will try to do better next time. So many of you have seen the objectives that we have today, and those are outlined here. How we can talk about healthcare equity around clinical informatics, and the impact of clinical informatics that we can use when we're looking at equity strategies for integrating informatics into policy development, and then how can we incorporate clinical informatics into teaching. And so really to sum this up, it's how can we use data thoughtfully? But I do want to lay it out at the beginning here, that this is not a talk about how we're going to use social determinants of health to drive national healthcare policy. A lot of what we're going to be doing today and looking at today really is down at the local level. So having said that, our journey for today, broken up into several different pieces, looking at clinical informatics and how that can inform policy, looking at clinical informatics and health equity. We'll go through several case studies. We'll talk about some barriers when looking at clinical informatics and policy and equity, and then no presentation about technology these days would be complete without talking about AI. And so at the very end, and this is the piece, stay with me until the end, because we're going to talk about some really cool AI pieces that are on the horizon. So to start with, talking a little bit about what is informatics, or what is clinical informatics. And when I think about informatics, really it's more about how we collect, store, retrieve, and report on data. And informatics in general is about how we take and transform that data so that we can use it kind of in an everyday situation. Clinical informatics then is doing that with our healthcare data. And in my role, my boss, Dr. Steve Morgan, oversees our health analytics and clinical informatics departments. So they kind of both roll up under that one arm that has the electronic health record that allows us to take input, store data, and then make that data available back to users of the system. And I work along with Jennifer Martin, one of our senior directors in nursing informatics, and she works more on the nursing side, and I work more on the provider side. But hand in hand, we bring clinical informatics to Carillion. So the role of clinical informatics in healthcare, and I have a number of images that I'll be using today that pop up, and I will tell you that most of these were generated using AI, using in ChatGPT. And so this is ChatGPT's rendering of how we use clinical informatics in healthcare. And I have these three pictures remind me to talk about the one on the right represents our corporate level. So how do we use clinical informatics at the corporate level here at Carillion Clinic? And one of the ways we do that, or several of the ways that we do that, is we look at how many providers do we need? How many nurses do we need? How many exam rooms, office practices? How do we use supply chain information to make sure that our ORs are stocked and that we have an appropriate number of vaccines? So all of that is taking in data that we have to make those types of decisions at that corporate level. The next level down, and this is referenced by the image there on the left, which is supposed to represent clinical informatics at the department level, or the individual office level. And I love the way that GPT has put the little awnings on there to make the doctor's office look a little bit like a restaurant. But at the department level, we use informatics around metrics of how well we are taking care of our patients. So what percentage of our patients with high blood pressure are controlled? How well are we doing on our diabetes control with A1Cs? Are we screening our patients for depression with the use of the PHQ-2, PHQ-9? We use informatics around work. So when we look at our nursing staff that are handling in-basket messages, who's completing the work? For our providers, who is doing more work outside of work, or work outside of work, pajama time, who's working on their notes at night, and where we might need to intervene and help those providers to on their well-being journey, looking at time and in-basket, note length, things like that. And then there in the middle, it's all about the patient, right? So how do we use clinical informatics when it comes to an individual patient? So things like clinical alerts, sepsis scores, drug allergy interactions. So when a provider gets ready to write a prescription for a patient and the patient has an allergy, using that data in the chart to alert the patient or the provider that, hey, you might not want to do that. And so we use clinical informatics at all these different levels. And so as we go through today, we're going to continue to talk about policy around policy as it relates to Carillion Clinic and what we do. And I definitely want to steer clear of that notion of national or state politics, because that adds many more levels of complexity. It's complex enough here at Carillion, and especially this time of year. Sometimes when we talk about state or national policy, healthcare policy, it can become a very emotionally charged subject, and so we're gonna avoid that. So we talked a little about policy. I do want to talk about equity, and I use this picture here of the pizza because this is kind of how I get in my mind equity and inequality. And so the example is, if we have a pizza and it's divided into eight pieces, And I think I have 4 people with hands in there. I kind of looked at the fingernail polish in a couple places and figured out we have 4 individual people. It's like, how do we divide up the pizza? Well, if we're going to divide the pizza equally, everybody gets 2 slices. But maybe a more equitable way to divide the pizza would be, give more pizza to the people that are more hungry. Maybe less pizza to people that are dieting. And so there are different ways that we can divide up that pizza based upon some other parameters that might be more equitable, but may not be equal. And so when I think about healthcare and healthcare equality not being the same thing as healthcare equity. And this is just a personal comment here about equity and equality. When we talk about equitable division, the question pops up in my mind: who decides? And an aha moment for me as I was putting this presentation together was that sometimes equal is easier to agree upon than equitable. And I don't know if that's unique, but or if I should say, I'm this many years old when I realized that equitable and equal are not the same. But that was the aha. And just to call out that neither equitable or equal will be fair. So a lot of times we get into what is fair and what is not fair, and I try to stay away from fairness as well. So in the end, talking about policy and equity, what we're really looking at here is how can we use our clinical data so that everyone can attain their full potential for health and well-being. And that's when I think about healthcare equity and clinical informatics, that's what I start to think of the goal being. That said, given that this is a discussion about equity and healthcare equity, I felt obliged to at least include a slide on social determinants of health. And social determinants of health include those things like income, housing security, education, unemployment, child abuse, neglect, neighborhood conditions, social support, the ability to obtain food. So a lot of different pieces go into that. And when we talk about those from an electronic health record perspective, several different levels. And so the first piece is capturing that data in the electronic health record. And for a long time now, that has been varied, but we're getting better. And so we're developing those standards so that we can gather data discretely into the electronic health record. There have been some tools for collecting that data. A couple of the tools, one is called Prepare, and that's Prepare with an A, which stands for Protocol for Responding to and Assessing Patients' Assets, Risk, and Experiences. There have been several others, one called Health Begins or WellRx, and those are slowly starting to be incorporated. Additionally, we can use natural language processing and machine learning. And so the ability to go through a document, so progress notes or other patient documents, where we can pull out information from those notes and then use that, converting it into discrete language. So some organizations are working on that. That's not on Curlian's roadmap so much at this point in time, but maybe in the future. And then there are other organizations that are working to mine things like social media for race, ethnicity, suicide ideation, opioid use. Again, we're not doing that here at Carillion, but some other organizations are leveraging that more from a research perspective. So once we've gathered the data, another area that is challenging is that sharing of data. And so while we have it in our system, how do we share that with our with organizations that are close to us or even further away? So how does Carillion and HCA, how do we communicate around social determinants of health? And I can tell you it's not well. Most of that is in the form of kind of free text, if you will, so not discreetly. We do better within Epic to Epic. So working with UVA, Duke, Inova, we're getting better on sharing those discrete elements between the two, between those different entities, given that it's all within the same setup, Epic to Epic. In terms of gathering, sharing, and so as we move into using data, once we've collected that data, what are the different ways that we can use social determinants of health? And I have them outlined on this slide here, kind of in the middle. First piece being, once we have the data, can we find places where there are disparities? So what are those disparities? Doing research into those areas. The second piece, once we've figured out that there are disparities where they exist, taking a deeper dive and trying to understand why, what is causing those disparities to exist, and then finally, the last piece is doing something about that. How do we reduce that? And I will point out that Rush, in Chicago, a group practice there in Chicago, they have done an amazing job utilizing their social determinant of health data within their EHR. They have they've programmed in the kind of in the back end that when a disparity is identified, that it generates a consult in the back to a community organization that can help the patient. So, for example, if a patient comes in and we've identified that they live in a food desert, and so that there's food insecurity in the background. Nobody has to click a button or get a pop-up or anything like that. It just generates a consult to a community organization, perhaps a food pantry, to notify them that now we have a person that has some food issues, and that community organization then can reach out to the patient and help out. Just kind of happens behind the scenes in the back, which is really incredible, I think. So last point here, incorporating the social determinants of health into teaching. And I would say at this point, for most of the learners that I work with, and would be in the clinical setting, just setting an intention to ask the questions and then follow up. So whether that's on a weekly basis, picking a different social determinant on a week-to-week basis or on a month-to-month basis. And so maybe October could be domestic abuse or food insecurity. Kind of pick your topic, but as you're talking with your learners, just ask, how is this thing affecting your patient? And in most cases, probably not, but every now and then you'll find that one area that pops up that allows you to have the conversation. And then once you've identified the patient with the disparity, being able to link them back to community resources or resources within the clinic to help out. Okay. So let's transition a little bit here and talk about the importance of involving equity when shaping policy. And my first thought was all policies should be equitable, like duh. But what does that mean? And so I found a really interesting article, and this was in the Journal of the American Medical Informatics Association, a study that was done. The original study was looking at whether or not an electronic summary versus a paper summary for people with implantable defibrillators would I think would be more understandable, and so the research took place, and then they came back on the backside and did some additional analysis, and that's what I want to focus on today. And so the enrollment, I have that here on the slide. They looked at patients with ICDs, these implantable defibrillators, and reached out. And obviously, some people said, no, I don't want to be part of the study. Those that agreed to be part of the study, they then asked some technology questions. Do you have access to a computer? And do you have internet access? Because they wanted to send these summaries electronically. And so if they did not have access to a computer or internet, they were randomized, or they weren't randomized, they were placed over in what we'll call Group C, which was became the control group, a control group. And then for those that met the technology piece, they were randomized into Group A or Group B, and one group got the electronic summary and one group got a paper summary. But the interesting piece with this study was that they went back and compared Group C with the intervention or non-intervention groups, so Groups A and B. And what they found was that there were significant differences between these two groups. And so, for example, Group C, on average, 23% of Group C did not graduate from high school, whereas only 5% from the combined A-B group. In general, income was lower in Group C, 40% versus 9%. Group C had higher rates of chronic disease. So in Group C, 27% had lung disease versus the other groups at 9%. Diabetes was higher, 44 versus 21%. And so the point here is that based upon the methods, there is this enrollment bias that occurs. And so here at Carilion, Carilion Clinic, we're younger to research. And so as we start to look at the ways that our policies and procedures around study enrollment and research, we need to keep this kind of thing in mind, that we can have this enrollment bias. And so if we truly want good data, good equitable data, we need to bake these things into our processes on the front end. Another example of some studies that I took a look at. Again, this comes from the Journal of the American Medical Association, but American Medical Informatics Association. I was reminded back in September, they had this announcement where Roanoke City is no longer in the top 10 for non-fatal opioid overdoses in the US, and how how we've done, and we've done an incredible job here in Roanoke around our opioid pieces. This particular article that I was looking at enforces the need for good quality data, and is around overdose deaths, not specific to opioids, but in general, kind of all overdoses, but found that people that were dying from overdoses in counties that had higher income, they were less likely to have unclassified overdose information in the death records. Also, racial and ethnic minorities were less likely to have unclassified drug overdoses, and so this leads to without having kind of the full picture, if we're going to target interventions in specific counties, not having a full data set may lead to mistargeting. So rather than focusing on opioids, we may target on meth, cocaine, other pieces like that, and that applies to kind of all aspects of the data. Here at Carillion, again, I mentioned Dr. Morgan earlier, but Jason Brown, who's our enterprise data analytics officer, it's his role to make sure that our enterprise data warehouse, that the information that's going in there is as complete as possible, and that we can report on that in a meaningful way. And he does an amazing job. But again, kind of coming back to data quality is key. So getting good data, making sure we're storing that in a way that can be reported on is very important. Switching gears to some case studies, and this is my technology and colon cancer image. And so here at Carillion, we obviously do colon cancer screening, and for the purposes of this talk, when I talk about colon cancer screening, I'm lumping screening and surveillance, kind of all those aspects together, and my GI colleagues may throw things at me for doing that, but it really is about who needs a colonoscopy that doesn't have colon cancer, and starting to talk about, well, what is equitable when we talk about colonoscopy screening, and as our surgeons and gastroenterologists are working down the backlog, how can we use data in a way to help prioritize keeping things equitable? So many of you may know that there are multiple ways to screen for colon cancer, colonoscopy being one. FIT testing, so looking for blood in the stool, is another. And when we think about people having colonoscopies, people with a positive FIT test, that have screened positive because there's blood in their stool, they move higher up the list in terms of people who need a colonoscopy, because now you have a person that has a much higher potential for having something going on. Also, people that have had a colonoscopy previously that had issues and need to be rescreened or followed up, they need to move up higher on that list compared to, say, a 45-year-old with no previous issues that wants to have that first screening colonoscopy. They're going to be a little lower on the list. And one of the things that we're doing here at Carillion to help with that prioritization is we are using a third-party system to do some natural language processing on old or older operative reports the procedure reports, the previous colonoscopy reports, the pathology reports, to pull out information from those reports that may not be discrete in the need for follow-up for a colonoscopy. So if a patient had a colonoscopy done and it kind of meets the care gap, so the screening interval for colonoscopy should be every 10 years. And so the provider says they've had that done, and so they're good to go. Perhaps in the operative report, the gastroenterologist indicated, based upon the procedure, that the patient needs a follow-up in 5 years. And if the provider missed that, or if that document came in from another organization, and the patient has moved in between hospitals or something, and the provider does not realize that the patient needed a 5-year follow-up versus a 10-year follow-up, we're working to go through with that natural language processing and pull out that data and present that back to the providers to say, here's a patient that needs follow-up kind of outside of what we're currently recommended, and so we can then stratify them and get them back in, get them back in sooner, so that we can do the appropriate screening. And so again, another place where we kind of look at that equity, who needs to go to the top, based upon their risk scores. Another area where we use informatics around equity here at Carilion. For those of you that don't know what this is CTAC, and this is kind of the brains of bed management here at Carilion, put together with Paul Davenport and his team. This is an amazing, amazing facility. And if you've never had the opportunity to go over and take a look at CTAC, it's futuristic. But basically, this is a command center that looks at all aspects of bed management. You can see on the screens there. There looks like in the middle they're looking at weather data, and you see maps of the area. They really do have their finger on the pulse of our bed utilization. And they continuously tweak their processes so that we are using our capacity to its fullest. But they're looking at who needs a bed, how many beds do we have, how many beds are we going to have, who's going home, so that they can allot those beds to the people that need them most. So not only patients that are maybe boarding in the ER that need a bed, but they're also looking at surgical cases that will be coming in today. So what surgical cases are we going to do where the patient won't go home, where the patient will need to have an inpatient stay afterwards. They're also looking at patients that are in outlying hospitals, outlying Carilion Clinic facilities, outlying other facilities where patients need to be moved to a higher level of care, and they're coordinating all of that using data and algorithms to figure out how to assign those beds as they come available. Just truly fabulous. So another area where their policies and procedures are really aimed at being as equitable as possible. This is my rapid fire slide. It has several other areas where we're promoting equity through Carilion Clinic policies and processes. There in the middle, that bright colored slide that is labeled healthcare, that's AI's representation of access to care in in a health system. And one of the things that we are doing right now with Dr. Mike Jeremiah, he's heading up our Access to Care initiative. And so looking at how we can provide access to more patients and do that for the patients that need to be seen most. So in dermatology, where we have a waiting list, or rheumatology, where we have a waiting list, are there ways that we can identify those highest risk patients and move them up the list so that they can see our rheumatologists and dermatologists? And one way we do that is through the use of e-consults. And so our primary care providers nowadays, if they have a question about a particular patient with a certain diagnosis, or maybe an uncertain diagnosis, they can reach out to a specialist through an e-consult, provide some information to the specialist, and get those questions answered. And so that can do a couple things. One, it can start treatment earlier, so we can start treating the patient before they get to the specialist. The other thing that can do is that can help move that patient up the list. So the specialist says, here are some things you need to do, and we probably really need to get that patient in to be seen. And so they move up that list a little bit higher, because they have their needs are bigger. Same type of thing in dermatology. You have a patient that maybe has something that looks like a melanoma. We're going to move a little bit faster to get that person in than, say, somebody who has acne. But through the use of e-consults, we can start treatment for one or both of those in the interim. Another area that we are where clinical informatics comes into play, and will come into play even more so in the coming years. There on that middle slide that says throughput, that's OR throughput, and so that's GPT kind of visualization for increasing OR throughput. And I know that that Dr. Tony Spall has made this an issue, a larger issue as we look at 2025. He's working very closely with Stephen Laverne in the OR to look at how we can improve throughput, and they're using a lot of data to do that. So things like OR start times. Are we starting on time? Do we have the timing for different procedures correct, so that we really are making the most efficient use of our OR time? Are providers using their block time appropriately? Are there places where we can do better? Also looking at the processes around the OR. So can we get patients to the OR faster from a primary care office through the specialist into the OR? And what are we doing then post OR in terms of overall length of stay? Are there things that we can do to continue to decrease that length of stay so that we can input the throughput, or we can improve the throughput? I have sepsis on here, sepsis and deterioration, other areas that are near and dear to my heart, working with Dr. Kramer and the CAPS group. Some amazing work in sepsis, helping to implement the EPIC early warning or early sepsis detection, which is a machine learning algorithm that helps identify patients that maybe have sepsis that we may be missing. And so each patient gets a score, if you will, that the higher the score, the more likely that the patient is developing sepsis. And so once a threshold has been achieved, we can notify a nurse or a provider. On the nursing side, the nurse can do a further evaluation to help us figure out, is this really sepsis, or if it's not. We've even have gone so far as to implement some policies that allow the nurse to implement an order set. So some specific orders, none of which are medication orders, but some lab orders and some other things that allows us to help figure out, is this sepsis or is this not sepsis? And then obviously more work in terms of treating sepsis. So using that data to help identify the patient so we can intervene earlier. Likewise, we have a tool called the Rothman Index, which is a sign of deterioration. And so taking a number of data points from the chart, combining those using machine learning, we can say, here's a patient that is deteriorating. We might not be able to identify why through the index, but we can identify that some things have changed for this patient. And now we need to notify the provider, we need to notify the nurse so that they can step in, reevaluate the patient from a rounding perspective, maybe move that patient to the top of the rounding list so we can figure out what's going on. Lastly, I have the joy of medicine, because when I think about healthcare equity, it's about helping everybody kind of live to their fullest. And so provider well-being is very important. And so are there things that we can do within the electronic health record or within clinical informatics to help provider well-being? And that would be things like looking at the pajama time or the work outside of work, looking at note length, time that people are spending in their in-basket doing that type of work compared to their peers. So we know that providers are going to have to write notes, and providers are going to have to be in the electronic health record doing things, but are they doing so more than their peers? And if they're doing things more than their peers, helping to understand why, and are there things that we can do, like additional training for the provider? Maybe their workload is higher than their colleagues, and we need to cut back on their workload. But taking that first step into identifying, where do those disparities lie among our providers, and then being able to adjust as we go forward. Well-being, I think we're gonna be seeing more and more of that in the coming years, which is a great thing. All right, as promised, and I think this is my last slide, or second to the last slide, talking a little bit about AI and the future, and the future is here. So everything that we're going to talk about on this slide exists today. So this is not vaporware. These are things that are present. And so the first, looking at risk scores, companies like Evolent and Aledade, they are taking electronic health record data, claims data, and they're the terms that I've seen, they run the data through deep learning models. And they use words like vectorization and eigenvector, but basically they develop this risk score, or how much it'll cost to take care of this particular patient with all of their various conditions. So a cost model, and then they get into prediction. So if we do these targeted interventions, it will cost this much to take care of the patient. So what's that difference in cost that we can realize if we have these interventions? And in some organizations, that's helping to guide those clinician decisions. So around cost. The other area, and this gets to the AI navigators, and I think this is amazing. So companies like LivePerson, Amelia, and Deliver Health, they're developing tools to translate complex medical jargon into understandable language. And this leads to patient empowerment and can improve compliance with medical regimens and medical plans. Now, one company has something that's called, they call them answer agents. And it's AI that draws from like knowledge documents and other websites that the company has to answer patient questions. So almost a little chatbot-ish, but helps those patients with that low health literacy. Additionally, what are called action agents, a little different than the answer agent, but the action agent can help automate processes that encourage and enable patients to do self-service scheduling, can help with billing, that management of appointments. And for people that may have a difficult time navigating the system, these AI navigators kind of sit on top and help with those things. Kind of a digital front door in some cases. And then finally, this notion of a pocket doctor or Dr. Google. And there are a number of companies that have been popping up. Sensely, Ada Health, Exund are a few. And these companies are getting into more diagnosis and personalized care. So like the Ada app has a system, a symptom checker where it interacts with the patient, and supposedly, and I have not seen the data on this, but supposedly the Ada app has been better than human doctors in accurately diagnosing some rheumatological diseases, skin rashes, and the source of abdominal pain. In this, I believe this was done in an emergency room setting. So these apps are getting better and better. But one of the things that these tools help with are around access. So when we have patients that are living in places where they don't have easy access to healthcare, yet they do have a cell phone, they can put their information in that cell phone and get answers that can help navigate the system. Or in some cases, and this is the way that some of these groups make money, is that they then convert into a telemedicine visit or telehealth visit, and so they can then interact with a physician if they need to. Okay. Lots of fun things on the horizon. So just want to bring back, do a quick wrap up in terms of what we've talked about today. Clinical informatics should be part of the discussion as we're forming policy. And so if you remember back to the pre-enrollment bias that we saw with the implantable defibrillators, as we're forming policy, how can we bring those types of discussions into that policy? We've got to have good data. We've got to have accurate data. How do we collect social determinants of health and other data that will affect patients? And then the last point, in terms of integrating this into your teaching, just simply be intentional. Pick an area weekly, monthly, and focus that in asking the learners, and just kind of make that part of the teaching as you go forward. And so now is the time for questions. That's again that I asked ChatGPT to develop a picture around technology and clinical informatics and questions, and so that was the piece that popped up.
Lovely rendition. Thank you so much, Dr. Speaker. This is just lovely.
Yeah.
Who has questions? What kind of questions do we have for Dr. Speaker while we have him with us?
The initial
I know what that is coming in the background.
Can you hear me?
Yeah.
Hello.
Yeah.
Hi, my name is Milena Steikova. I am from Radford University, and this semester I teach graduate students. And one of the topic is health informatics and the use of artificial intelligence and ChatGPT. I asked the students to create a policy for like support of ChatGPT, and it was very interesting how the students are more like inclined to not to see the benefits of it, but to like prohibit the use of ChatGPT, prohibit the artificial intelligence. So how do you like any suggestions, any tip to provide that there's a positive like implication of artificial intelligence, especially in clinicals?
Um, no, it's a great question. And, and one of the things I think about and have talked with several learners about, is I don't think that ChatGPT is going to replace doctors and nurses and other people, but ChatGPT and Copilot, et cetera, large language models, people that use large language models will replace those that don't. So I don't think banning or preventing use is a good direction to head in. I think the question becomes, how do we thoughtfully incorporate these large language models into what we do? Because if we don't, if Radford and Carillion and in other areas, if we're not doing that, we certainly know that other organizations will. And so as we've seen with the application like Ada Health, right? People are doing that, and if we're not keyed into how to use these tools, because that's what they are, tools. If we're not keyed in on how to use tools correctly, other people will figure that out, and that will put us at a disadvantage. So you've got to understand the limitations, right? Please don't put health information into ChatGPT unless it's a secure Carillion or a secure Radford large language model. But certainly asking questions of GPT will get you answers, and then you need to verify them, right? Because you can't trust everything.
Thank you. I do see us moving, like it or not, we're all moving in that direction, right? So I like it towards the end when you were talking about, Dr. Google, just a few years ago, you would walk into a doctor's office and they'll be like, well, tell me what Dr. Google told you. And they were sort of afraid of what patients were coming in with, what type of information they're coming in with. Nowadays, that your patients are coming in with that information, and it helps that physicians are getting on board, other providers are getting on board and saying, okay, let's work together with what you've seen and what we've seen. And then wouldn't it be lovely if at some point we could get to where physicians and other providers could recommend some types of AI that were reliable, right? As opposed to just not knowing what you're going to get. I would envision that would help out from those patients who, instead of searching or looking into it themselves, immediately jump on my chart or something along those lines, which can be overwhelming for physicians who would like to end their day short of 22 hours. Those types of things. So I love the fact that we're sort of getting to the point where we're realizing this isn't going to go away. So how do we work together and really make sense of the resources, the tools that we have? Other folks, what kind of questions? We have just a few more minutes. Any questions or comments?
Dr. Speaker, great presentation. One of the most powerful ways that we can really use The EMR for research purposes is my chart. But as you know, we only have about 45 to 50%, people in it. And when you look at who's in it, it generally tends not to be people with SDOH. So is there ways or mechanisms that we can use to basically get more people on my chart? Because this would be a great avenue for recruitment.
Oh, golly. You ask a great question, and I don't know of easy ways to make that happen. I think that there's some opportunities that we have with our patient experience group to continue to refine some of the pieces around my chart. But at the end of the day, it comes down to access to the app, access online, and making it easier. So I think it's a journey for us here in Southwest Virginia. I think other places that have higher technology uptake may be easier, but I think it's going to be a challenge for us as we go forward.
Thanks.
A question in the chat. Can you speak to the role that data sharing agreements play in operationalizing or not clinical informatics?
Yeah. Yeah, data sharing is fun, and I will first of all say that I am not an expert when it comes to data sharing agreements. That's where Jason Brown and his group are very helpful. But Carillion has a lot of data in their EHR, and the question becomes, I think in my mind, is how do we appropriately partner with others around that organization or around that information? And currently, kind of a challenge between Virginia Tech and Carillion in terms of access to that data. Like I said, I don't have the answer, but making sure that we have good agreements for data sharing is key.
Thank you so very much. Is there anybody with one additional question before we wrap today's session up? Quick question, anybody comment? Got a lot of comments in the chat, just thanking you for a great presentation. Okay. Well, fortunately, Dr. Speaker is right here and local with us, so available for questions following our session. He's in Outlook, so feel free to reach out to him if you have additional questions or you'd like to have conversation about this beyond today's session. Other than that, I hope you all have a wonderful day. Stay safe.